Hi, welcome to NEET PG Core Revision series in Pharmacology, where I will be discussing the important topics for the upcoming NEET PG examination. So today we are going to talk about anticoagulants and antiplatelets. So first I'm going to tell you or take you through the important drugs and classify them. So in the anticoagulants first, we have parenteral and the oral anticoagulants. So in the parenteral anticoagulants, we have indirect and the direct thrombin inhibitors. In the indirect thrombin inhibitors, we have heparin, low molecular weight heparin, fondaparinux and danaporoid. So in the low molecular weight heparins, you have to remember certain names. So all of these will be having a suffix which is your parin. So parents. Even fondaparinux you'll see has a parin image. So you know that it's a low molecular weight heparin or belongs to or is related to heparin. Then we have direct thrombin inhibitors which have bivalirudin and argatroban. In the oral anticoagulants, we have vitamin K antagonists, especially important is your warfarin. Then direct factor 10 inhibitors like rivaroxaban, apixaban. So they have N10A, right? So you know that it is a 10A ban. It bans it. That means it is an inhibitor of it. Oral direct thrombin inhibitors, we have dabigatran. So now we move further to the first important drug, which is warfarin, the oral anticoagulant. So in this, what does warfarin do? So what is the mechanism of action of warfarin? It inhibits the enzyme VKOR, that is vitamin K epoxide reductase. So it will not allow the reduction of vitamin K to occur. We know that vitamin K is responsible for the activation of the clotting factors 2, 7, 9, 10 from the liver. So when warfarin is given, it will interfere with this process. So there will not be any synthesis or the activation of these clotting factors. So therefore, the anticoagulant effect will ensue. So what are the important things or points you need to know about warfarin? Number one, that when you give warfarin, you don't see an immediate action. Why? It is going to inhibit the synthesis or formation or activation of the newer these clotting factors. But whatever already has been synthesized, that will not be acted upon. So it has a lag period of 4 to 5 days, right? Because it inhibits the newer factors, right? The newer clotting factors. So the first factor which is affected or inhibited is factor 7. The last factor to be affected is factor 2. Now, this is a picture which can be shown as an image-based question. In the question as would go by that what is the drug causing this, right? Which drug has caused this? So answer is warfarin. Now, this is the dermal vascular necrosis which is seen with warfarin, and the reason is that warfarin also initially inhibits the synthesis of protein C, okay? Protein C. This will increase the risk of hypercoagulability, right? It will increase the risk of hypercoagulability initially. So therefore, this problem of dermal vascular necrosis can occur. Therefore, what we do usually is alongside we start heparin also, so that till the time warfarin exhibits the action, you can continue heparin and then later on withdraw. Then next is, what is warfarin used for, or it is a drug of choice for what? So it is a drug of choice for prophylaxis of thrombosis in valvular atrial fibrillation. Mechanical valves. So it prevents the thrombosis whenever there are mechanical waves in the valvular atrial fibrillation. Now, warfarin is a teratogenic drug, so it is contraindicated in pregnancy. Okay. Now, why? Because it can lead to fetal warfarin syndrome. So this is a picture of a baby whose mother was given warfarin. So it's a fetal warfarin syndrome. So there can be this very typical feature, depressed nasal bridge. So it is a depressed nasal bridge. Then patient can have hydrocephalus. There can be short limbs and digits in the baby. Now, important antidotes to know. So, for warfarin, the important antidote, like if there is an excess of warfarin which leads to bleeding, what can you give? You can give vitamin K. That's the specific antidote. But if it is a severe bleeding, then we also give 4-factor, this precipitate of the plasma, because all these 4 factors, 2, 7, 9, 10, they are the specific factors which are inhibited with warfarin. So you can give them specifically, but they're expensive then. Right, so it is the specific antidote here is vitamin K. And then for dabigatran, what will you give for dabigatran? The antidote is idarucizumab. Direct factor 10 inhibitors, which is rivaroxaban, apixaban, what will you give? You give andexanet alpha. Again, it contains XA in this spelling. Non-specific antidote for the unfractionated heparin, low molecular weight heparin, Fondaparin, NExT, dabigatran is Siraparantag. Siraparantag. So this is a non-specific, not very specific. Then another picture-based question or image-based question can be asked with this picture. And what is this? This is a purple toe syndrome. Rather, it's a purple foot syndrome. Not only toe, but the whole foot is involved. But the reason is different. Again, this is seen with warfarin. But the reason is there is cholesterol crystal embolization. These crystals, they usually dislodge and then they go and travel to smaller blood vessels. So this is the cholesterol crystal embolization that is seen. Then parenteral anticoagulants. So we will compare the important points in the parenteral anticoagulants. So here we see between unfractionated heparin, low molecular heparin and Fondaparin. So the unfractionated one is, they are very huge molecules, big molecules as compared to low molecular weight, and the Fondaparin has the least molecular weight. Now, unfractionated heparin, it inhibits both 10A and 2A. Low molecular weight heparin has more effect on 10A, while Fondaparin, it only affects or inhibits factor 10A because of the size, Then the routes are usually subcutaneous. You can give unfractionated heparin as such also by the IV route. Risk of the side effects are highest with heparin as such as compared to the others. So what are those risks? The risks are thrombocytopenia, osteoporosis, and this heparin also requires monitoring. So we monitor the APTT, which is not required in case of low molecular heparin and in case of Fondaparin. Now, heparin is a drug which can be given in renal failure as well, because it is mainly metabolized by liver. But low molecular heparin and Fondaparin, they are mainly eliminated by kidney. Therefore, these two cannot be given in kidney failure. Please remember this. Then all of them, they are safe or they can be given in pregnancy, because warfarin cannot be given, but these can be given. So they are used in various, especially in cases of huge or big surgeries like the cardiopulmonary bypass, we prefer to give heparin, and the other surgeries like DVT prophylaxis, etc., we can give low molecular heparin, or we can also give Fondaparin. So let's see what are the other important features we need to know. In the parenteral direct thrombin inhibitors like valirudin, ergatroban and milagatrin, so they require APTT monitoring. Remember, they require APTT monitoring. Ergatroban is a drug of choice in heparin-induced thrombocytopenia, the HIT syndrome. What is the drug of choice for this? That is ergatroban. But ergatroban has no antidote as such. Then the antidotes for heparin, it is protamine sulfate, another very important question. But remember, it does not reverse the actions of Fondaparin, only for heparin and low molecular heparin, and more specific for heparin. So they are used, these are used for catheter-induced thrombosis. Side effects of heparin, remember the mnemonic bleeding hota. So bleeding, H for hyperkalemia, O for osteoporosis, thrombocytopenia, that is the HIT syndrome, heparin-induced thrombocytopenia, for which the drug of choice is ergatovan, and it can cause alopecia. So this is the table telling you about the choice of anticoagulants in various conditions. For example, in pregnancy, in the first trimester, we prefer the low molecular heparin or the heparin as such. Then in the mid 13 to 35 weeks, we can give warfarin, but still we prefer to give low molecular heparins. Then towards the end, that is 36 week onwards, we again will prefer to give, in case warfarin is given in between, we switch on to low molecular heparin. Peripartum, stop the low molecular heparin 24 hours before the delivery, and we resume it after 4 to 6 hours after normal delivery, or 6 to 12 hours after lower cesarean section. Breastfeeding, we prefer warfarin. Prevention of DVT, again you should be giving low molecular heparins. Prevention of stroke and embolism in valves, if the valves are involved, in mechanical valves, we give warfarin. If it is a non-valvular atrial fibrillation, then you give directly acting drugs, orally acting anticoagulants. Then in the DIC, again we are going to give unfractionated heparins. So these are the important choice of anticoagulants in the various conditions. So let's do a MCQ from the previous year. A patient on antiplatelet therapy started complaining of reflux esophagitis, for which he was prescribed omeprazole. After a while, it was seen that the patient suddenly developed slurred speech and numbness in his limb. This was attributed to decreased efficacy of the antiplatelet. What was the most likely drug here? Aspirin, clopidogrel, streptokinase, or tirofiban? So the answer here is clopidogrel. So this is now your antiplatelet which has come into picture. We'll see how is the answer correct when we are going to study about the antiplatelets now. So the antiplatelets, the way when you classify these antiplatelets, so one is the inhibitors of thromboxane A2 synthesis, which is aspirin, and this is also in low dose, remember. Then inhibitors of P2Y12 receptor of ADP, we have reversible ticagrelor and cangrelor, and the irreversible we have clopidogrel, prasugrel, ticlopidine. GP2B3 antagonist, we have epsiximab, eptifibatide, tirofiban. Protease activated receptor antagonist, we have vorapexor. Then phosphodiesterase inhibitor, which is dipyridamole. So let's see how they work. Now here I'm going to draw an platelet, let's say 2 platelets. Now how does this all these mechanisms work in platelets? So inside the platelet, the COX leads to formation of thromboxane A2. So when aggregation has to take place, on the other platelet, there is a receptor which is present for thromboxane A2. So this thromboxane A2 released from one platelet is going to act on its receptor, and it is going to cause the aggregation of the platelet. Number 2, what is happening here is the cyclic AMP, it gets converted into the ADP, and this is with the help of phosphodiesterase. So cyclic AMP is anti-aggregatory, but ADP is pro-aggregatory. Now ADP also, when it is released, has receptors on the platelets, and the platelet receptors for ADP here. So this is the receptor for the platelets here that we have for the ADP. This is P2Y12. So when your ADP is going to be released, it is going to act on this receptor here. Again, this is going to cause the aggregation of the platelet. Coming to the GP2B3A. Now GP2B3A, they are not active as such, but when there is platelet aggregation going to occur, they become activated, right? So here let's make this is a, so both of these platelets, they have GP2B3A receptors. So then they are going to stick to each other. So they are going to stick to each other like glue. So This is again a method of addition of the platelets, aggregation and addition of platelets. So all these things are ultimately going to cause aggregation and addition of the platelets where there is injury or where the platelet plug is being formed. So whatever drugs we are going to give, they are going to block these processes. Then there is another receptor also present here. Oh, here we can draw. This is a receptor which is called as PAR1 receptor. Now this is receptor where the thrombin binds on the platelets. Again, it is going to cause aggregation here. So whatever drugs we are giving, they are going to block this. So aspirin is going to inhibit this step, doesn't allow the formation of thromboxane A2. Then ADP antagonists or P2Y12 receptor blockers, they are going to block the receptor here. GP2B3 antagonists, again they are going to block this, so there's no attraction addition between them. Then we have PAR1 antagonists, they are going to block this receptor. And the last one, phosphodiesterase inhibitor, they are going to inhibit this particular step. So there will be less ADP formation, more of cyclic AMP formation. And I told you already, the cyclic AMP, this is an anti-aggregate or anti-aggregator. So it is going to not allow, it is not going to promote aggregation. So it is, we are increasing the levels of the anti-aggregator. So this is how these drugs are going to act. So mechanism of action of first, very important, is your aspirin. So aspirin is a thromboxane A2 synthase inhibitor, and this is how it works. It inhibits the COX enzyme, and it is an irreversible inhibitor of COX, right? Remember, this is an irreversible inhibitor, and we call such drugs as hit and run drugs, right? Important. So in the platelets, it is going to inhibit thromboxane A2, which is actually a pro-aggregatory molecule. So because these platelets, they do not have nucleus in them, so new thromboxane A2 cannot be synthesized by them. So new platelets now have to be formed, and therefore this is called as a irreversible action. In the endothelium, if you give a higher dose, what will happen? Why low dose we are concerned with here? Because if you give a higher dose, then it also inhibits the prostacyclins in the endothelium, right? That is, so it is anti-aggregatory. So pro-aggregatory, anti-aggregatory, both the effects, they will get nullified. And endothelium, the thing is, it can still resynthesize the prostacyclin even if it is being inhibited. But platelets action is basically irreversible here. Now, aspirin is used in stroke, myocardial infarctions, and currently now we prefer to give another antiplatelet along with aspirin. But it's a very, very good drug to be used in these conditions. It is contraindicated if the patient has peptic ulcer and lactation because it has tendency to cause bleeding. So, in peptic ulcer patients who are at risk of peptic ulcer, we tend to avoid giving these drugs. Then GP2B3A inhibitors, these are considered to be one of the strongest antiplatelet drugs. So remember the mnemonic T, TEA, tirofiban, eptifibatide, epsiximab. So all these three are GP2B3A antagonists. Eptifibatide is the shortest acting out of the lot, right? And these can be given easily in renal disease. Then the next we have the protease activated receptor antagonist, that is Vorapaxar, and it is given in oral form and for MI prophylaxis with aspirin. So aspirin is a mainstay. You can add on other drugs with it, right? Contraindicated in case of in the cerebrovascular attacks we don't give, but in myocardial infarction we can give this drug. Then P2Y12 blocker. So very, very important thing is clopidogrel and prasugrel. So this is ticlopidine. We don't use that because it has a lot of side effects, but yes, we use clopidogrel. Now, we did in the question before the interaction between omeprazole and clopidogrel. So, what is this clopidogrel? It's actually a prodrug which needs to activate in the body. So, in the liver, there is the cytochrome enzyme CYP2C19 which activates it. So, until unless it is not activated, it won't be able to produce the effect. So, let's say the patient is being given clopidogrel and you also give omeprazole to this patient, which is a proton pump inhibitor. So what this omeprazole is going to do, this omeprazole is going to inhibit this CYP2C19. It's an inhibitor of the cytochrome. So if omeprazole inhibits CYP2C19, then the clopidogrel is not going to be converted into the active form and it will lead to failure of therapy in that patient. So we should not give omeprazole along with clopidogrel. Secondly, because of genetic variations in individuals, some people might have the CYP2 CY9, which is not very active, which is very slow, or in some they can be very fast. So in people where the enzyme is slow and not very active, then again the clopidogrel will not be as effective in them as is in the other population group. So instead, because we cannot give omeprazole, what you can give other PPIs who have less of these drug interactions like rabeprazole and pantoprazole. So clopidogrel is best combined with aspirin because it has a synergistic action with it. So we for these days for percutaneous coronary intervention, we give aspirin plus this clopidogrel. So the dual antiplatelet therapy, even in my current faction now, we give a dual this therapy of aspirin along with clopidogrel. So this is very, very important drug interaction that you should know. Now, prasugrel is also a drug, pro-drug, but it is activated very, very fast. So, in this population or in this drug, this interaction is not very significant because of this, because it's very, very fast. Now, remember, it's a very, very potent drug. Now, prasugrel is so potent that it can increase the risk of intracranial bleeding in these patients of stroke. So therefore, especially in case of elderly population or people who have a risk of stroke, there we do not give prasugrel, right? So these are the important points which we must know about anticoagulants and antiplatelet drugs.